So, welcome to Pyramid Ultrasound Training Institute. First of all, this is not a training course. Whatever we are conducting right now is a question and answer session. So this is a question and answer session for our registered candidates who are undergoing different online server-based course. So this is not a course right now, whatever we are taking. This is a question and answer session for those who are registered with us for different courses. Today, we got some questions from our registered candidates. I will display the questions. First question is, sir, regarding the knuckle fold, you have told that 8 to 10. You have told that 8 to 10 mm is borderline and greater than 10 mm is abnormal. But in diagnostic ultrasound by Rumack, this is the book Rumack, greater than 6 is abnormal. Knuckle fold thickness is written as abnormal. These are the copy pasted questions. What I mean by copy pasted questions, as we got this, we copied and just pasted so the language is original. And the next question from same doctor, that is Dr. Rajesh Das, is that, sir, is there any normal range of insular depth? And what is the significance of insular depth? So the second question is regarding the insular depth. I am giving you the sum up of the question. First thing is the knuckle fold thickness. Knuckle fold thickness, not knuckle translucency. Don't get confused. I think that Dr. Rajesh Das is confusing between the knuckle translucency and knuckle skin fold, knuckle fold thickness. I mean, we will discuss that. And second is regarding the insular depth. What is insular depth? This is the question posted by Rajesh Das. Second question by Dr. B. Sai Sunil. I'm very sorry if I'm pronouncing it wrongly. Dr. B. Sunil is sending us a case, and I will show you the case. Now, his writing is this pattern. Which pattern? I will show you. Of thyroid disease suggestive of thyroiditis or Hashimoto's. And how to, second part question, how to measure the ITA peak systolic velocity, internal thyroid artery peak systolic velocity in thyroid disease, to differentiate between the thyroiditis and Graves' disease. This was the question by Dr. B. Sai Sunil. Third question by Dr. Zainab is that please explain the scar thickness. This scar thickness, we are getting frequent questions on this scar thickness, how to take, where to take, what is normal. I have taken before this also 2 to 3 sessions on this scar thickness, but maybe that this batch was not there. So I will take this thing in detail today, how to take the scar thickness and where to look for what is normal range. How to measure, what are its normal values. Same question has been put by Dr. Papu. Then Dr. Zainab is sending us a case which I will show you, 40 years of age, P3, L3, A0 with complaints of heavy bleeding during menses, but regular cycles, day 13, endometrial thickness is 19. I will show you the case. We will discuss the Dr. Zainab's question, where the endometrial thickness is on the upper, I will not say upper, is abnormal, is increased. We will discuss this. And then the Dr. Ravi is sending us again the case. Please interpret the Doppler. Gestational age was 34. I will show you the case. We will discuss. So these are the questions which we have taken for today. We will discuss these questions. But before going to questions, if anybody is having any question right now, but the first priority will be for these questions. I have taken the printout of these questions. I will discuss a long list of questions, but I will take maybe 1 or 2 questions from you. If you are having any question, raise your hand. I will take your question. Not this physical hand, not this physical hand. There is a more option. 3 dots are there. There is a more option. You have to click on the more, and raise hand option will pop up. You have to click over there and we will unmute your system. But a request, if you are having a background noise, please don't raise your hand, because your background noise will disturb whole of the class. So the condition is that you should not have a background noise. If you have any questions right now, please raise your hand. I will be waiting for 2 minutes for raise hands. Dr. Sweta Gautam Ahuja has raised the hand. Let me see her question. Let me unmute her first. I am sending the unmute invitation. Please accept it, and on accepting, say hello.
Hello,
Hi,
sir.
ma'am. Yeah,
Hello,
hello.
sir.
Hello.
Sir, I am doing the basic obs gynae course. I wanted to know, sir, what is the difference between anti-flexed and anti-verted uterus? Means how do we differentiate it in ultrasound?
Anti-verted and anti-flexed, right?
Yes, sir.
Okay. Anything else?
No, that's it, sir.
Okay, thank you. Shreya, please note this question. Anybody having any more question? No. Okay. How to differentiate an anti-verted and an anti-flexed uterus? Am I audible? Yeah, clear? Why it is not coming over here? Okay. First of all, let me take the question from the list. So I'm trying to draw on whiteboard. So it will take a minute. Is it there, Shreya? Whiteboard has come? Yes, no? Whiteboard has come. Set this also. Okay. So I do have the list. Let me take first the question, how to differentiate a blood clot from a retained product of conception. And the doctor, I don't have any name over here. So anyhow, the question is how to differentiate a blood clot, from an RPOC, retained product of conception. So the only thing which will differentiate a blood clot from an RPOC is the color, Doppler color. So if you are putting a color, first of all, you are taking the uterus, most probably in longitudinal section, it will be more visible. So you will be seeing first the section where you will see more of that clot, or in inverted commas, RPOC. So first thing, you got it. Then you have to put color. Onto this thing, and if it takes color, then it cannot be a blood clot. It has to be a retained product of conception. On gray scale only, you cannot differentiate an RPOC from a blood clot. You have to go to the Doppler and you have to investigate on Doppler. If it shows flow, I mean the vessels, the color there, then it is a retained product of conception, RPOCs. So this is the brief answer for this. But I am having one more point which I want to discuss with you, is that if you are not seeing any color, not color, sorry. If you are not seeing any retained product of conception or any RPOC over there, if your RPOC in that uterus is very small and is not picked by ultrasound, how you will detect that small retained product of conception? Now, if patient is bleeding, not mild, severe bleeding over there, then how can you say that there is a retained product of conception? Again, by this color. You put a color box, and you see a vascularity, and that vascularity is confined to a very small area. Make a note. Despite of non-visualization of RPOCs, if you are having a small area of increased vascularity, it means that the retained product is very small, or it is not picked by you. It is not coming in that section. It is not in that slice, but your color is telling you, doctor, there is a vascular area in this specific area. I am having very color vascularity. It means that retained products are there. So the other point is that despite of non-visualization of RPOC, if you are seeing a hypervascular area, then it is RPOC. So this way you can differentiate between the two. Now, the next question from same doctor is that on TVS, we are not always seeing the ovary. The point here is that what does mean? Yeah, here. Now the point is that whenever you are inserting the probe, now see, you are inserting the probe. You are inserting the probe. When you have inserted the probe, what you are thinking that the ovary will be always and always here and here. Then what you are doing, you are making the probe to target onto this side and onto this side. So whenever you are inserting the probe, you are tilting it this way and this way, thinking that ovary is having a fixed location. Do ovary have a fixed location? A big no. Then why you are expecting the ovary to be exactly at that point where you are thinking always it to be? Ovary can be somewhere here high up, over here, or maybe over here. Then your probe has to be this way. Now, how can I say where is the ovary? So the point is, before taking a TVS, take a transabdominal scan. Whenever you are taking a transabdominal scan, transabdominal scan will give you an idea of location of ovary. And if the ovary is down inferior, I mean in cul-de-sac, then you have to go to the cul-de-sac when you are inserting the probe. So don't expect the ovary to be at fixed right or left at 30 degree or 40 degree away from here or there. No, you have to search for ovary. First, go for a TS scan, because TS scan is having a broad field. Then only insert the probe. And even if you have inserted the probe, you have to search for the ovary. So that way you have to sometime bend here. You have to bend, you have to lean your body here so that your probe will go and send the beam to all corners of pelvis. Not inserting the probe, angling it this way and angling it this way will not give you ovary in all patients. Now, knuckle skin fold. Now see, Dr. Rajesh Das, first of all, try to understand, clear the concept of knuckle translucency and how different that knuckle translucency is from knuckle skin fold, knuckle skin thickness. So what is actually a knuckle? Where is the knuckle fold? I mean the thickness. Now see, we all know how to take a knuckle translucency, anti scan. We will be taking a sagittal section And over here, we will be seeing a NT, that is knuckle thickness, knuckle translucency, not thickness, sorry, knuckle translucency. When we are taking knuckle translucency, up to 13 weeks, 11 to 13 weeks, max is 14. So about 13 weeks, we are taking NT, knuckle translucency. Don't get confused between the knuckle thickness. Now, what is knuckle thickness? Anybody? What is knuckle thickness? Knuckle fold, knuckle thickness fold, not knuckle translucency. Anybody having idea? Please raise the hand. Not this physical hand. There are 3 dots over there. Or mention in comment box. The easiest way to mention in comment box. Should I keep an eye on the comment box? Mention in comment box. What is knuckle thickness? Not knuckle translucency. Comment box. Hurry up. Hurry up in your comment boxes. This is not the time to send your question in comment box. Questions have been already finalized. We are now discussing the question in comment box. What is knuckle thickness? Distance between Dr. Anusha. This is the answer. I'm displaying the answer also. Distance between occipital 1 and the skin. Okay, this is a spell mistake. This is not 1. This should be bone. Occipital bone and the skin. Yes. Now see, when we are taking this knuckle fold, knuckle thickness, when in comment boxes, now it is not a unilateral platform over here. You have to participate in your comment boxes when we are taking the knuckle thickness. Not translucency, thickness, knuckle thickness. At which gestational age? Hurry up in comment boxes now. Hurry up. Dr. Virushali Gorao, 11 to 13 weeks. This is the point. No. The confusion is here. Thank God my nose is working. I mean, my smelling power is intact. I can smell whatever you are thinking. I was expecting this answer to be there, 11 to 13 weeks, and it came. Not once, but twice. Now see. No, 11 to 13 weeks. I have repeated just 30 seconds before that we are taking knuckle translucency at 11 to 13 weeks. Knuckle translucency is different. Not the knuckle thickness. Knuckle thickness is something which we have told that is the thickness over here, the skin, beneath the skin up to the occipital bone. When we are taking Dr. Priyanka, 16 to 24 weeks, very good. Dr. Vidya, 14 to 18 weeks, also good. Dr. Lopamudar, 16 to, now you are coming on track. So the point is the knuckle thickness, the fold thickness is not taking at 11 to 13 weeks. 11 to 13 weeks, we are taking NT, but after 14th, I will not say 14th, 16th, after 16th week onwards, up to 20, 22 weeks, we are taking the knuckle thickness. Now, how it looks on screen, I have showed you. We have discussed that thing in detail in the class. I will try to show you some slides of knuckle fold, not knuckle translucency. I have kept one slide for you. If it comes in pop-up, let me see. Came up now? Yeah. Yes. Now see over here. This is the knuckle fold over here. This is the knuckle fold. This is occipital bone over here. This is occipital bone. Now see, this is the occipital bone. I'm drawing on this. Now this is the thickness of the occipital bone. Do I include the occipital bone over here? No. So excluding the occipital bone, everything above the occipital bone, but not include the occipital bone. And we have discussed it when to take it. So whenever I say that 10, that 10 is not for knuckle translucency, Dr. What is the name? Dr. Rajesh Das. Whenever I am talking of the knuckle fold, I mean this fold NSF, knuckle skin fold. 8, 9, and up to 10 is borderline, and 10 above is abnormal. So I hope that Rajesh Das has got a detailed answer. And the second question is, what is the normal range of the insular depth? First of all, what is an insula? What is an insula? Whosoever is having this unmuted microphone, please mute your microphone. Everybody, please check. Please mute your microphone. Now, the insular depth. This is the insula. This is the insular depth from the central fax. You will see, let me change the color. You will see a hyperechoic line over here. Now see, you will not see a complete, but a partial linear structure over here. So this thing is the insular depth. So you have to measure from the central fax up to this hyperechoic line. So this is the insular depth. So this is the insular depth. Now, how much is the insula itself? The depth of the insula, I mean, it varies. It depends on the gestational age, and it increases from, you can note it down, at 19 weeks, it is about 15 millimeters. So note it down, 15 millimeters at 19 to 20, take it 20. Easy to memorize. 20 weeks, 15 millimeters, 15 millimeters at 20 weeks. And as pregnancy advances, at about 30 weeks, it is 25. So it increases, sorry, it increases up to 30 weeks, it is 25 millimeters. I am repeating, it is 15 millimeters at 20 weeks, and it increases from 20 weeks onwards, it is 25 millimeters at 30 and up to 35 weeks. Now, the significance. Why should I know about this? If we are having a fetal brain migration disorders, in fetal migration disorders, brain migration disorders, I will be having an abnormal insular depth. So this was a very brief reply. I'm very sorry, my briefs are very detailed, I know that. So I hope that you have got your answer. Now, next question. First of all, peak systolic velocity. Now the question is very lengthy, how to differentiate between thyroiditis and the Graves' disease on the basis of the IPA, PSV. First of all, let us see a slide. Let us see a slide over here. Keep this slide whenever you are doing ultrasound of thyroid. Keep this slide ever in your mind. So, whosoever is doing a thyroid scan, keep this slide in your mind once for all. Inflammatory, this we have discussed in detail in our class. Now, the point here is that Hashimoto's disease. This Hashimoto, is this an autoimmune disease? Yes. Decurvence, is that an autoimmune disease? No. Acute sporadic thyroiditis, is that an autoimmune disease? No. Graves' disease, is that an autoimmune disease? Yes. So The point is, we are having two autoimmune disease. One is Hashimoto's. That is why it is painless. We have discussed this slide in great detail in our course. We will not take course over here. We will take the question. So the point is, in this Hashimoto disease, the peak systolic velocity will be high of IT, inferior thyroid artery, peak systolic velocity will be high. But in Graves' disease, it will also be high. So where it will be more high, in thyroid, in Hashimoto's or in Graves' disease? In your comment boxes, where will you expect? Though both are autoimmune disease. So the point number one is that peak systolic velocity in inferior thyroid artery will be high in case of Hashimoto's as well as in Graves' disease. In your comment boxes, where do you expect more it to be, in Graves or in Hashimoto's? In your comment boxes now, 15 seconds only. In your comment boxes now, Shriya, comment box. Dr. Sunil, Dr. Zainab Graves, Dr. Anusha Graves, very good. And somebody, Dr. Manish Tiwari, Hashimoto's, Dr. Shriya Shekhar Graves, yes. Graves' disease, 90% are with Graves' disease, so more will be in Graves' disease. That is what is written over here. That is what you have been taught, that peak systolic velocity above 100 centimeters per second in case of Graves' disease, and in case of Hashimoto's, it will be about 60 centimeters per second. Now, you might be thinking, not all of you, some of you might be thinking, how to see for that? Why is that peak systolic velocity? Let me draw how to see this peak systolic velocity for freshers. So I will come to that, but before that, do I have anything to show you over here? Yes, I do have. So now see the case which I told you that I will show you some cases which have been sent by the same doctor. Is this pattern, remember this slide over here, is this pattern suggestive of thyroiditis, Hashimoto's or Graves' disease? Now I am showing you some colors over there. I mean, the vessels are increased, but I will not say that this pattern is typical for Graves' disease. I told in class that if you see thyroid on fire, inferno, it means that you will be seeing more of vessels like that, everything is on fire. This is not a typical, I'm saying typical, this is not a typical for Graves' disease, but still it can be. Now, what will decide over here? The peak systolic velocity, which I will draw for freshers, how to see for that. For me, it doesn't look like Graves' disease, because in Graves' disease, I will see almost no tissue when I am putting color. I will say only color and color only. Believe me, if you see once the thyroid inferno, I mean the Graves' disease, you will that will get pasted into your mind once for all. So, doctor, this case has been sent to us by the same doctor, Dr. Rajesh Das. Now, I am having for gynecologists. There is a case which has been sent by Dr. Ravi Divakar Ratlam. Please interpret the Doppler of GA 34 weeks. Now, this will take time. Now see what is happening over here. The point here is that, first of all, where is the uterine artery? I suppose that this is the uterine artery. Let me zoom onto this. Here, this is the uterine artery. Now, in uterine artery, I am having some mild retention, not a very prominent retention over there. And let me zoom this. Shreya, please zoom on this. Yeah, zooming. Now see, the doctor is putting, oh my God, what I'm seeing, left uterine artery over here. The left uterine artery is completely abnormal. And again, now the left uterine artery is this. Now the point is this the left uterine artery or this one the left uterine artery? Before sending the case, please have a look on your case, what you are sending. Now, if this is the left uterine artery, then this is very abnormal left uterine artery. Now, let us take this as a left uterine artery, and maybe that this is another uterine artery. The doctor has just labeled this as left. This is actually the right. So abnormal uterine artery is over here. Now, this is the abnormal uterine artery. It means that there is an impaired trophoblastic invasion. So this fetus should have in IUGR. Which IUGR? Asymmetrical IUGR. Now I will not take complete color Doppler over here because I will start talking of color Doppler. I will not stop even for next 24 hours. Now the left uterine artery is abnormal. Then what is the status of the umbilical artery? What is the status of umbilical artery? Let us go for the umbilical artery. Now the S/D ratio of the umbilical artery looks not very abnormal, but the diastolic flow looks dipped. So it means that there is a this placental obliteration. Oh my God, what is the status of the middle cerebral artery? Middle cerebral artery is over here. Does not look like a high systolic velocity flow, because if it is abnormal, then there is a brain sparing effect. You know that those who have completed the color Doppler will understand me. Others may not understand me because this is a very lengthy discussion. What is going on this right now for the interpretation? You have to have a clear understanding of the all flows, which you will come to know when you will complete the color Doppler. So does not looks like a brain sparing effect. Now let us see which vessel has been taken by this doctor. Left. So first of all, what I will say, this is not a complete scan. This is not a complete scan. Why? Because I am not seeing any fetal aorta. I am not having any inferior vena cava over here. I am not having any umbilical vein. And I'm not having a ductus venosus flow. Now, what to do? With these flows only, abnormal uterine artery, have a look on the middle cerebral artery. In this middle cerebral artery, I am not seeing any increase in the flow, so I will not say that brain sparing effect has started. It means that redistribution has not been started yet, but it can be a pre-terminal stage. Why? Because maybe that this is a drop after brain sparing effect. For that, I need fetal aorta, which is missing over here. So if fetal aorta is normal, then we can wait for before termination, we can wait for some time. But if fetal aorta is abnormal and this is the condition of the MCA, then that is a pre-terminal stage. So what will decide over here is the missing aorta. So this was about this case. Do I have anything to show you more over here? No. Now, yes, I will show you over here without drawing on the board. I will show you over here what is the peak systolic velocity. Now, if any velocity has been taken, not over here. Yes, let me see over here. In this picture, it is not coming, but you will search for. Yes, it is there. Now, what is the peak systolic velocity? Whenever you are taking a flow. Now, I'm coming to another question, the peak systolic flow. Peak systolic velocity. Whenever you are taking any flow, this peak, now see, this peak is the peak systolic velocity. Now, how much is that peak systolic velocity? You have to see for a scale which is over here. Here. So in this case, the peak systolic velocity is about a 40. It is not 50. So this way, you can make out the peak systolic velocity. So have a look on the scale which is there when you are measuring the flow, see for the peak and correlate it and see the graph, I mean the scale, and that way you can see for the peak systolic velocity. Okay. So let me close all this and come to the last question, which is very, very lengthy. Is the scar thickness? Before scar thickness, I had another thing. What was that? What was that, Shreya? Some case, no? Yes, I had a case which I have to show. A case sent by some doctor. Yes, here. Now see, this is the case which has been sent by Dr. Zainab. Dr. Zainab is our old student. She is from UAE, I suppose. Yes, she is from UAE, most probably Dubai. Now see over here, the endometrial cavity. Now see the endometrial cavity. This is the case which has been sent to us for discussion. The endometrium, because there is something in that endometrium, and that something is hyperechoic. Now see, this is the way you have to think. This endometrial thickness is increased. This increase is attributed to something of being in the endometrial cavity, and that something, whatever is there, is hyperechoic. What it means, what it can be, polyp. But before jumping onto the polyp, I have to see the this day of cycle. If I am in late excretory luteal phase, then I will rescan the patient. But this patient, as per Dr. Zainab, is not in luteal phase. Day 10th, day 11th, she told me. So this is most probably a polyp. On grayscale, it looks hyperechoic, and let us see what it is showing on color. So the color has been put, and I am seeing a vessel. This can be a feeding vessel. So this can be a feeding vessel. I am seeing a single vessel over there. So this can be a feeding vessel of a polyp. So if I have a video over here, yes, I have. Dr. Zainab send us the video also. Now see over here and concentrate yourself and give the opinion what this can be. See over here. A single vessel is coming into this area, which is very hyperechoic. And this is not a luteal phase. This is day 10, day 11. But I will say, had this been a day 2nd or day 3rd, the things would have been very, very clear. But even over here at day 10th, it looks like a polyp, nothing else. So now going to the detailed one is, let me close all this. So now going to the scar thickness. So first of all, regarding this scar thickness, what should I see? What should be the choice of investigation, TVS or TAS? The choice of investigation is, of course, TVS, transvaginal scan. Dr. Fayaz Ghani, please mute yourself.
Okay, sir.
So the choice of investigation is transabdominal scan, TAS, transabdominal scan. The point is that whenever there is you are seeing a scar, where to see? Gynae knows that we are giving incision in lower uterine segment, so we have to see at the level of the isthmus. Now this is the isthmus over here. So this isthmus stretches This lower uterine segment stretches. This isthmus stretches to be what? Lower uterine segment. And it is the point of this lower uterine segment where I will be expecting this scar. So this is wire to see. Then when to see. Then when to see. Scar thickness is usually seen in third trimester. Some argues for 38 weeks, but some suggest it to be at 36 only to avoid some change, to keep these all things in one plate. We will say that we will be taking at 34 and 36 weeks. So the point is, even some studies have been done in second trimester and late second trimester. But I will say go for 34 weeks, not after and not before that. But the point is, should I use transabdominal approach on full bladder? No. The problem with this is that with this full bladder, I may be having a miscalculation of the lower uterine segment, because with the full bladder, sometimes it gets stretched, and if it gets stretched, then it looks to me that the original scar, which is of 4 millimeters, for example, with a full bladder will get stretched up, and with stretching, what will happen to thickness is, of course, it will get decreased. This is the first point. But more important is the clarity. That transabdominal scan is not very clear, because whatever I am seeing is the very small area over here. This is at the level of the isthmus. I have to see this. What I have to see is the myometrium, not the scar itself. This is the point where most of the doctors are over-diagnosing. They think they are taking in account the scar itself, but we have to see the beneath endometrium. I'm repeating for the third time now. Don't take the scar, don't take that hyperechoic line. See for the beneath and myometrium, which is hypoechoic. So you have to measure this, not from here to here. That is why. Okay, I will come to that. Now see, let us stick over here. What is over here? This can be scar itself, but we are measuring the scar thickness, not the scar itself, but the beneath myometrium. What is over here? Wall. Which wall? Urinary bladder. Urinary bladder wall is itself measuring 3 millimeters. And if I will take the entire thickness, I am taking the urinary bladder wall thickness also. That is why when sometime a report comes to you that the scar thickness is 4 mm or maybe 5 millimeters, and you are not taking a chance of normal delivery, you are going for a cesarean section, and when you are taking the section, you are even seeing the hair of the fetus through that small thin scar, and you say to yourself, thank God, hey Bhagwan, aaj kar diya, kal to ye burst ho jata. What is wrong over here? Why that doctor has given you 4 millimeters when it was about to rupture? Because that doctor has taken the urinary bladder thickness in account. So that is why I'm stressing on to the urinary bladder. Don't take the entire thickness. By entire thickness, you are automatically taking the wall of the urinary bladder also. See for the beneath myometrium only, and myometrium is hypoechoic. That is why I am showing you this thing, not to include the urinary bladder wall. So, and normal. How much can be a normal? Now, when we are taking exclusively the myometrium, which is beneath the scar, even 2 is normal. Please focus on for 10 seconds only. Even 2 is normal. But when you are labeling 2, you are labeling the myometrium only. And if you are taking the wall also, then even 3 and 4 are not normal. So if you are damn sure that whatever I am measuring is the myometrium only, then even 2 is normal and 3 is supernormal. So the point is C for the myometrium, not for the whole thickness at the level of the lower uterine segment. Okay, exhausted? Not you, me. Okay, I hope that I have taken almost all questions, and if you will be having more questions, so if you will be having more questions, please post on our helpline number. You can send, and we will take your questions on next interactive session. Okay, so thank you and God bless all of you. Stay tuned and you can post your questions, but there is a request. Don't pose any question. What I mean by any question? By any question, I mean if you are right now taking, undergoing, I will say, the physics and machine settings and you have not touched the gynae ultrasound yet, please don't post any question from gynae. And if you have completed or undergoing the gynae, then you can post even from physics, machine settings and gynae, but you cannot post a question from a color Doppler which you have not touched yet. So the request is that post the question from the topic which you have completed or at least you are undergoing that. Thank you very much. God bless all of you. Stay tuned. See you next time.